All right, we're going to give everybody just one more minute as we still have some attendees joining. Welcome. Today we're going to be talking about CCRCs and transitioning through the continuum of care. To introduce our presenters today, we'll start with Emily.
Hi there, my name is Emily Lewis. I'm a physical therapist at a CCRC in Houston, Texas.
And my name is Brooke Buxton. I'm an OT and a director of rehabilitation at a CCRC in Athens, Georgia.
And I'm Christina Stevens. I'm an OTRL and I'm a regional clinical director at Aegis in Georgia. Just to review a few housekeeping items, please make sure all of your lines are on mute. If you have questions or comments, use the questions feature on your control panel and we'll try to get to all of the questions after the course. Be sure that you're using your own unique identifying login so we have a record of your attendance. Please give Shyla up to 2 weeks to process your certificate. If you're an SLP, you'll need to complete the ASHA bubble sheet that's required for ASHA, and you'll want to submit that to Shyla within 1 week for credit. Please download it from the handout section. Shyla's email is there at the bottom in blue. That's who you will email it to. And Shyla will be sending a quiz link to the OTs and CODAs the day after the course. Per AOTA, you're required to pass the post-test quiz for credit. If you don't pass it on your first try, please email Shyla and ask for a retake because you can have up to 2 tries to pass. The objectives for the course today are for the learners to be able to describe a continued care retirement community and the types of transition care settings within the CCRC environment. Identify best practices for successful transition for residents between care settings, and identify components of clinical program development for each of the care settings within a CCRC.
A CCRC, or Continuing Care Retirement Community, is a place where you have access to multiple levels of care on a single campus. The primary benefit of this kind of community is that it permits residents to remain in one facility while moving between the levels of care as their needs change. Currently, there are about 2,240 CCRCs in the United States, and the number of older adults living in CCRCs has more than doubled in the past decade, according to the American Seniors Housing Association. More than 500,000 older adults live in CCRCs, with numbers continually increasing. Yet few studies address the transitions between levels of care in these communities. The first level of care is independent living. This is where most people join CCRCs. They are independent with care needs, live in condominiums, homes, or apartments, alone or as couples. Services and amenities are available to them: lawn care, home care, maintenance, pools, and recreation. Optional service examples include activities, transportation, and meals, and many are fine dining meals indeed. These services are designed to promote an active and engaged lifestyle, and this level of care usually comprises the largest percentage of the community's population. The next level of care is assisted living or personal care. This level is designed for residents who are not completely independent and need some degree of assistance with daily tasks. There's 24-hour personal assist support. Personal care may include assistance with mobility, meals, personal hygiene, dressing and bathing. It has 24-hour nursing support, and basic medical care is provided, such as medication management and transportation to doctor's appointments. Another level is memory care. This is a specialized care setting that serves residents who develop dementia or require close monitoring due to certain behaviors. This is typically separate from the main community, and the staff there receive specialized training to provide care to those with dementia and cognitive deficits. These are secured communities. Then we have skilled nursing. This is an option for residents who need skilled, licensed nursing care and medical attention. This is the highest level of care in most CCRCs. Some residents transfer to this setting temporarily if they're sick or recovering, such as a respite stay. Additional medical equipment is available in this setting, and assistance for all needs is provided here. CCRCs are subject to regulatory requirements. The Fair Housing Act and the Americans with Disabilities Acts. The Fair Housing Act prohibits discrimination in the sale or rental of dwellings on the basis of race, color, sex, religion, national origin, familial status, and disability. The Americans with Disabilities Act prohibits discrimination on the basis of physical or mental disability in public accommodations operated by private entities. Long-term care facilities and nursing homes are expressly covered. For senior housing communities with elements of both residential dwellings and service facilities, both the FHA and ADA apply. The application process for a CCRC must fit within the legal framework of the prohibition on disability discrimination found in these laws. These are requirements for residency. Differences among types of senior housing can limit the types of permissible inquiry about a person's disability. All inquiries must be made of all applicants equally, whether or not they're disabled.
There is an application process to enter a CCRC to live. There's typically an application and an interview. Potential residents are given a tour of the campus and discuss the amenities offered. To move into a CCRC, certain requirements have to be met. Typically, there's an age requirement, a health qualification, as well as a financial qualification. As Brooke mentioned before, there is standard criteria a resident must qualify for to live in each care setting. Some CCRCs use the 4 S's to qualify for independent living, which include the resident's ability to self-evacuate in the case of an emergency, self-direct, the resident is safe for self and others, and also displays socially acceptable behavior. Living in place. Previously, you may have heard someone refer to aging in place. Living in place is the more current terminology. The goal is to have our residents not only live in place, but thrive in place. These are a few of the supportive strategies that are utilized if a resident starts to struggle in the independent living or the assisted living settings. A few of these strategies include therapy services, looking at DME, personal assistance, catered living, and caregivers or personal caregivers. Personal assistance and catered living do differ a little. Personal assistance would be A couple examples, maybe someone coming in to do some house chores, running some errands for the resident, or even performing their shopping. Catered living is usually provided anywhere between 1 to multiple days a week. We know that a lot of times our residents have a fall risk, for example, but we would maybe think about when they're at most risk for falls. So for catered living, perhaps someone comes in for mini visits. They could be as short as 30-minute sessions, perhaps, where they come in on Mondays, Wednesdays, and Fridays to provide supervision and assistance for showers, for example. Medication programs or services are also something that we would want to consider. Things like bubble packaging, or even dispensers, medication dispensers that could be connected to an app. Additional housekeeping services, delivery services, emergency alert systems, and tech devices such as Alexa or Google Nest that could do things, for example, like provide appointment reminders, medication reminders, or even technology to lock the door at night if the resident forgets to. I want to take a moment to discuss one of the biggest challenges for therapists who are new to a CCRC environment. And one of those challenges is really knowing and being able to identify when a resident is able to stay in the current care setting or when it's time to transfer through the care continuum. To optimize the therapist's role in risk reduction and transition throughout the continuum of care, it's important that the therapist get familiar with the criteria for each care setting and support systems that they're able to have in place in each of those settings. The brochure here listed on the slide is just an example of the list of services that this one CCRC Brandon Wild is able to provide throughout the continuum of the community. Risk reduction strategies will be discussed on further slides. Emily will go into that in a little more detail in just a few moments. We have our first poll question. So I'd like you all to think about who is part of the transition team in a CCRC. And here are the answers here. Shyla, if you'll please pull up the first poll question.
Okay, about 75% of you have answered, so I'm going to go ahead and close it. And it looks like 71% said all of the above, 27% said A and B only, 1% said therapy team, and 1% said social services.
All right, the correct answer is F, all of the above. Everyone on campus is part of the transition team and has a responsibility to report changes in residents that they've observed. Team-based care, whole person care, and comprehensive care with collaboration and communication across all the departments is crucial in determining the needs and the best care setting for the residents in the CCRC. Oftentimes, surprisingly, it may be that dietary or housekeeping staff are the ones who actually identify residents that are having struggles and communicate that to the team. Most CCRCs have meetings that identify residents at risk, like a collaborative care meeting that sometimes happens weekly. Occasionally, they'll do it bi-weekly. A member from most departments of the community, including the executive director, the director of plant operations, the chaplain, concierge, Medical director, social worker, nursing, maintenance, and all the additional departments you see on the slide attend that meeting. Everyone has a part in identifying the residents who are at risk. CCRCs typically complete a functional evaluation with a cognitive component to help the transitional team determine if a transition is actually needed. This is an assessment that scores basic ADLs all the way to the IADL categories, as well as mobility. Typically, if you score between 0 to 26, you qualify for independent living, 27 to 60 assisted living, and 61 to 80 for SNF. The components on the slide are discussed at the CCRC risk meeting as part of the functional skills assessment to identify which patients are at risk and which ones are appropriate to stay in their current setting or transition to a different setting. Transferring clinically relevant information to the next environment, including to activities, wellness, and restorative, is a key part of therapy's role in successful transitions. As therapists, we want to make sure that we are educating the patient, the nursing staff, the caregivers in their new setting in the areas in the blue box on this slide. So the amount of assistance the patient is needing physically, functionally, cognitively, their appropriate diet, communication strategies, as well as any adaptive equipment or special technique needs as well. We have another poll question here. So the second one is that research shows that transitions from one environment to another can negatively impact an older adult in all of the following areas except. So Shyla has opened that poll.
Okay, looks like about 75% of you have answered, so I will go ahead and close it. And 43% of you said access to the therapy and wellness programming. 35% said fatalism. 11% said social disengagement, and 11% said autonomy.
B is the correct answer, access to therapy and wellness program, because our residents are going to have access to therapy and wellness program across all care settings. This slide here is a research study that was done and published on residents' perspectives on transitions within a CCRC. And it gives a lot of insight because relocation into and between environments is one of the most stressful events older adults face. Transitions may threaten a resident's autonomy, social network, and sense of belonging. Forced relocation is especially stressful. Most residents that attended a grief group that was put in place at one of our CCRCs in Georgia were thought to be individuals who might be coming because they'd had a loss of a significant other. And what we found was really surprising, and it was that the grief that was discussed most frequently in that grief support group was about residents who felt they lost a sense of their previous life. For example, if they moved care settings from independent living down to assisted living, they had to move to a different setting, a different physical location within the CCRC. So their interactions, their social interactions change, their friendships changed, some of their access to activities changed, and also their independence and freedom and autonomy also changed with the move. Also, there is the fear and stress around fatalism and the thought of moving to a further dependent care setting, and how some of them reported in the study here that it gives you a different outlook on death and makes you a little bit more aware of the decline that you're having, whether that be cognitive, physically, or both. For residents, this signifies that they've closed a chapter in their life that they may not have been ready to part with quite yet. So we definitely just want to be aware as we're working with our residents from a therapy perspective. Of course, we do want to think about our traditional role in successful transitions and educating family and staff, identifying those physical, functional, cognitive, adaptive equipment needs that our residents have. But we also want to look at their mental health and their socialization, their engagement in activities, and be empathetic about some of the perspectives on transitions that our residents are having.
How to identify clinical needs in your CCRC for program development. So first, we have to recognize that every facility is different, so the needs of the patients will be different. You want to utilize your interdisciplinary team, your IDT meetings, as a means for identifying clinical needs. And you can do this by discussing residents that are at risk, have had a change of condition, any recent hospitalizations, any recent falls, residents who are new to the facility, and also discuss residents who are moving from one continuum to another. So people who are transitioning from like independent living to assisted living, or from assisted living to long-term care. Understanding the residents in your facility and the different diagnosis presents, the challenge that the residents face, and the residents' needs and wants will really help you focus your program development. So for example, if you're recognizing that there are over 20 residents in your facility that all have Alzheimer's diagnosis, or that you identify 12 falls within 1 month, this can help you identify which programs might be needed. Cross referrals from the IDT team are also important for opening up those lines of communication and identifying needs, such as cross referrals between the therapy disciplines. So PT referring to OT or OT referring to SLP, and also having ways for CNAs, housekeeping, and other team members to notify the therapy department of a patient's functional or cognitive decline. All of these things would really help keep the lines of communication open. Hosting marketing events and awareness events such as Meet the Team, Therapy Q&A, Meet and Greets, and exercise groups hosted by therapy will really bring awareness to the therapy department and how we can help. Providing the facility and patients with resources such as abilities checklists, Hey Rehab self-notification cards, and screening forms will allow the residents and staff to further reach out to the therapy department, and it will help you understand your CCRC's programming needs. So now we have another polling question. So which care setting is appropriate to address urinary incontinence within clinical programming?
Okay. 91% said all of the above, 5% said skilled nursing, 3% said assisted living, and 1% said independence living.
All right, so the answer is E, all the above. And the reason is because we're able to modify any clinical program that we might be creating. So for example, we can have a urinary incontinence program at every level, but the focus might be different. So for independent living, a urinary incontinence program might offer something like pelvic floor strengthening and avoiding diarrhea kept by the patient. But a urinary incontinence program in long-term care might consist of something like scheduled voiding, toilet training, and clothing management training. So now let's discuss the different levels through the continuum of care and how evaluation and treatment of patients changes as they move through these transitions. So two main points to consider in a CCRC when working with patients in the different settings are making goals and providing interventions for your patient's specific needs as they progress through IL, AL, long-term care, and memory care. So starting with independent living, our patients are higher level functioning physically and cognitively, so we want to set goals that provide interventions that will keep them functioning at this level for as long as they possibly can. So we're focusing more on tasks like leisure activities, pain management, fall prevention, community mobility, maximizing safety, and daily planning and scheduling. So here are a few examples of how we would address these topics. So I have goals on all of these slides. These aren't your typical like fully written out SMART goals or anything, but this is just to provide some examples. So for goal setting, your patient will be able to walk for 20 minutes in order to go to the grocery store. Patient will reduce back pain from 6 out of 10 to 4 out of 10 after standing for 10 minutes in order to wash their dishes. Patient will be able to ascend and descend 3 stairs with independence with a handrail on the left in order to get on and off the bus for the grocery store outing. Patient will demonstrate problem-solving skills 90% of the time given minimal verbal cues. The patient will recall to use a calendar to check daily appointments and activities at first practice across 3 consecutive sessions. So the way that we would address these goals is through interventions provided, such as modalities for pain management. So it really just depends on what your facility has as far as modalities go. But I know that, like, for example, at our facility, we have ultrasound, electrical stimulation, diathermy, paraffin, and of course, hot and cold packs too. We want to do soft tissue mobilization and manual therapy for pain management to improve the soft tissue and joint mobility, fall prevention and balance training, walking outdoors on uneven surfaces, and doing community ambulation that might include like curbs and ramps, dynamic gait and balance, stairs, and environmental barriers. We also want to maximize cognitive language skills to facilitate independence and safety in the home and community, and problem solving and scheduling. So when considering program development, ideas for independent living might include a freedom through functionality program. So this might include like equipment or gym training if your facility has that to offer, pain management, and fall imbalance. For assisted living, we want to focus on tasks and mobility that will improve their ability to function within the assisted living environment and to stay in assisted living to prevent that decline. Fall prevention and safety, and facilitate social interaction and communication. So a few examples for goals for patients in assisted living. Patient will improve sit to stand from patient's recliner from contact guard assist to standby assist. Patient will be able to ambulate 150 feet with supervision and 4-wheel walker and able to walk from her apartment to the dining room. Patient will demonstrate use of adaptive equipment such as a shoehorn independently or 3 out of 3 trials. Patient will be able to complete a toilet transfer with standby assist with use of patient's elevated commode and grab bar. And the patient will demonstrate the ability to sequence 2 to 3 step tasks during functional daily tasks with 75% accuracy, giving minimum verbal cues. So interventions for assisted living would include functional mobility. So things like sit to stands, transfers, and gait training. And this is in order to improve their function within their AL apartment and environment. which kind of goes into the next one, which is the task-specific activities. This is so important for assisted living. So if a patient is reported that they're having difficulty going from sitting to standing, then doing multiple reps of sit to stands with task sequencing and safety should really be a priority here. So instead of doing something like 20 reps of marching or long arc quads or heel and toe raises, you should really be practicing the task specific activity so that they can improve on their functional strength. In apartment training to adapt to their own environment, using their personal assisted devices and adaptive equipment is also important. So for example, performing toilet transfers in their own apartment will allow you to do the toilet transfer, ensuring that you're doing the proper directional transfer with the precise grab bar placement with their specific type of elevated commode chair. So this is important so we can ensure the patient is able to function within their own environment. Doing simulated trials can be helpful, but performing it in their own space is going to be more personal and specific to the patient and the type of equipment that they have. Introducing adaptive equipment such as sock aid, shoe horns, raised toilet seats, and reachers. So for example, like the patient's personal reacher to pick things up off the floor, or practicing using the patient's personal shoe horn to don and doff their shoes. Introducing an assisted device that they didn't previously use, such as a walker, rollator, or cane. So for example, if the patient recently transitioned from independent living to assisted living and they were reporting like a balance impairment or difficulty walking, or they're having an increased fear of falling, it might be needed to train on the use of like a rollator or a cane or two-wheel walker. In addition to training on the proper use, we also want to ensure that we're measuring for the proper fit and teaching safety, such as locking and unlocking brakes, maybe with a rollator that's including teaching them how to turn to sit on the rollator seat. We're also assessing and treating for adaptations that might be needed in their environment to enhance the independence and safety. So for example, if your patient has recently transitioned to maybe being in a wheelchair and now they're at wheelchair level doing most of their ADLs, consider lowering the closet rail in order to allow the patient to get their clothes in and out of their closet more independently, so that that way they don't have to rely on the nurses and the aides to get dressed. Task sequencing and safety recall, such as locking and unlocking walker brakes before standing, or safely sequencing through ADLs and functional mobility. The ability to follow a daily routine, such as performing morning routine ADLs, participate in structured conversations with familiar communication partners, and attend to basic tasks within their environment. When considering program development, ideas for assisted living could include continence management, fall and balance, posture and positioning, Alzheimer's and dementia management or complex disease management, and low vision and home safety. For long-term care and skilled nursing, we're focusing on improving mobility and also preventing decline, reducing assistance needed from caregivers, diet modifications or dysphagia management, engagement and participation in daily tasks and activities, and effective communication. So goal setting in this setting might look like patient will be able to roll from left to right with min assist in order to assist with changing and dressing. Patient will improve toilet hygiene to min assist. Patient will be able to patient will be able to self-propel their wheelchair 125 feet in order to get to and from activities or bingo with supervision. Patient will be able to tolerate a regular diet with thin liquids without clinical signs of aspiration, with independent use of compensatory strategies such as small sips and slow rate of intake. Patient will demonstrate ability to retrieve words during responsive naming tasks with 70% accuracy. So for interventions to address these goals, they might include things like functional mobility in order to improve or maintain their current functional levels. Contracture management, this definitely could be needed, and you might want to consider things like positioning devices, splints, and modalities in order to maintain or improve their range of motion. You also might want to look at patients who might be appropriate for a functional maintenance program or walk to dine, and promote participation in activities. You may also be introducing an assisted device that they didn't previously use in the setting as well, such as like a walker or a wheelchair. So if they're transitioning from assisted living and have had a decline in function, a wheelchair might be a consideration in order to reduce the patient's fall risk. Again, when you change or add an assisted device, training is always needed to ensure the proper positioning, safety, and proper use and management. Diet modification and dysphagia management may be needed to ensure that patients can consume their current diet and medications safely. This may also include ordering swallow studies along with caregiver and staff education. We also want to enhance our patients' communication skills. This can be done through many ways, maybe through object identification, yes and no answers, or this may also indicate a change of means of communication, including like written, verbal, or electronic. When considering program development, ideas for long-term care could include seating and positioning, continence management or toileting program, and dementia management. For memory care, we're focusing on contracture management, wound prevention and positioning, diet modification or dysphagia management, cognitive levels and memory, and caregiver and staff training. So a few examples of goals would be instructing caregivers in a safe feeding program with appropriate setup and cueing to initiate and sustain action and sequence steps. Develop behavior management program with a 2.6 cognitive level appropriate activities to decrease risk of falls. Perform bed to wheelchair transfers with mod assist with caregiver providing the appropriate cognitive level cueing. Patient will increase orientation to person, place, time, and caregivers to 70% of opportunities to improve functional communication skills. So for interventions, it's very important that we do an assessment of their cognitive level in order to appropriately set our goals and provide the most appropriate and effective treatments. It's also important to identify cognitive levels in order to provide appropriate activities and leisure tasks for the patients that they can participate in and enjoy. Once identifying the cognitive level, this may also include training for the activities director, staff members, and caregiver education on cognitive level approaches with the residents in order to promote effective communication with our patients and also the highest level of independence and safety. Other interventions might include sensory stimulation programming for lower cognitive levels by incorporating activities that engage various senses to maintain and improve cognitive function, including memory, attention, and executive function. Diet modifications, dysphagia management, and long-term care and memory care is especially important because there's a significant number of patients with dementia, Alzheimer's, and other progressive diseases, which often require diet modification due to the progression of the disease. Again, here, contracture and wound management is important, ensuring weight shifting, positioning changes, and proper positioning, whether that be in the bed or in the wheelchair. Stretching and range of motion programs, and considering if splinting or modality use is appropriate. Functional ADLs and mobility is also important here to promote the highest level functioning possible and prevent decline. And then, of course, continuing to work on memory, orientation, recall, and safety. When considering program development, ideas for memory care could include wound care, contracture management, dysphagia management, and dementia management. So transitioning off of skilled therapy services. When transitioning off of skilled therapy services, we want to provide patients with the tools, education, and resources in order to maintain and even just continue to improve on what they've already established in therapy. Some of the ways that we do this is through education on wellness and programs that may be offered at your individual CCRCs. This could include training your patient on the use of your community gym facility and equipment, if you have pools, providing information on classes such as Sit and Be Fit, or directing to programs provided such as Fall and Balance. We also want to ensure understanding of our patient's home exercise program and make sure you're providing like printouts, education on their program prior to discharge from therapy. We also want to follow through on referring appropriate patients to restorative nursing programs and providing proper training and handoff to the restorative nursing aides. And finally, we want to ensure caregiver training and support has been provided, such as providing or recommending appropriate adaptive equipment. So for example, if a patient has been training with a 4-wheel walker, then you want to make sure you're providing that appropriate recommendation to the patient or family. If they choose to buy one, or if they're able to go through their insurance to get a walker, you just want to make sure that communication has been completed, and that if you've been training with it, then that's what you should ensure that they have upon discharge. Or if OT's completed training with something like a reacher to prevent falls in their treatment plan, then ensure the patient has one upon discharge. We also want to provide communication, we want to provide education and ensure understanding of cognitive levels in order to promote improved patient-centered care and to make sure we are providing recommendations for cognitively appropriate activities and leisure tasks for the patients. It's also important to communicate and provide training with family and staff on assistance levels and how to best assist the patient for functional mobility, ADLs, and IADLs. So for example, this might look like providing CNA's training on how to transfer a Max Assist patient who has back pain and is able to just follow one-step commands. And finally, we want to ensure that emotional support is being provided to the patient and or family members as well.
I apologize. Somehow it's fast-tracked back to the beginning. This here is an example of a success story and also a patient testimonial that's used for one of the CCRCs that Aegis provides therapy services in. And it just goes to show how important it is to create presence and awareness of our therapy services within our CCRC communities. So this gentleman here is Mr. Frank Spears, and in his own words, his testimonial is, sometimes when life throws you a curve, you need to find a pro to help you. Why in the world would you want to go anywhere else with incredible therapists so close to home? Caring and concern is a quality that is so important to healing. The therapy team are good listeners. They keep trying to improve your health. Without OT and PT, the road to healing is way too long. Accelerate the healing process with professionals that really know what they're doing. So this is just a great example of a resident testimonial. That concludes our presentation for today. If anyone has any questions, if you'll use the questions feature in the chat, and we will work our way through the questions and answer all of them.
Okay, there is a question. I'm going to go ahead and answer it. The next step for ensuring we get credit for attending, speech, you will download the ASHA bubble sheet from the handout section, and you will send it to my email. That is Shyla, SHYLA, .Hamrick, HAMRICK, @aegistherapies.com, and that's how you will get ASHA credit. If you're wanting AOTA credit, there will be a quiz emailed to you tomorrow. You have to pass that quiz in order to get credit, and you have 2 attempts. If you do not pass the first time, it's up to you to email me and I will send you the second link. PTs, we have requested for Minnesota, California, and Florida. Certificates will be sent within 2 weeks. There is a question, are most CCRCs private pay?
Brooke, do you want to answer that one?
Yes, I would say most CCRCs are private pay, if not all.
Okay. How do you determine the level of care when cognition or medical status fluctuates?
The level of care is determined by the transition team, as we kind of discussed earlier. And so there's so many different components to it, functionally and cognitively, as well as to each resident's unique resources. Because in the CCRC environment, oftentimes a lot more than some of our other environments, we see a lot of private caregivers, the personal assistants, the catered living. And so it really is going to depend on the amount of assistance they have. And then also, you know, kind of determining the family, the responsible party, as the level of assist goes up. Is it really worth, for example, staying in independent living, but having to pay for increased care by an hourly rate that may require up to 24-hour caregivers versus transitioning to the next care setting? Maybe that's ALF if it's next, where that care setting provides that services and that additional help that better meets that resident's specific needs already. And so it's so unique. It's not just one answer across the board, but a lot of times if a patient's cognition fluctuates, if it's a particular time of the day, then that may be where they have more care assistance. But typically you want to plan for their lowest level of need or their lowest functioning level, and make sure that from a safety, functional, and a cognitive standpoint, that patient has the support and assistance that they need at that level.
And I'll just add, I mean, that's an excellent question. And that's why CCRCs have, and they may call them different things, but risk meetings, where all of those different departments we talked about meet together and look at the patient over time. I mean, is this something that's going to resolve? Should the nurse practitioner give in and get involved with, you know, med management? Do they need a respite stay to get looked at a little bit more intensely at the SNF? Should therapy get involved and do another, you know, we do Allen cognitive model here at Aegis, you know, and we can compare them to their baseline. It's just like Christina said, it's a case-by-case basis, and probably each CCRC is going to be different how they handle it. But it's an excellent question, and that's where the rubber meets the road, transitioning between these levels. And
I wanted to touch on something. If you are a PT and you are in a state that I did not say that we have requested from, if you know your state's reciprocity, that they are a state that accepts other approvals, they will accept Florida, Minnesota, and California. Can you give examples of sensory stimulation for the cognitively impaired?
Emily, you want to take that one, or would you like me to?
Sorry,
Okay.
I was still sorry about that. I was still on mute. Well, my background is mostly in physical therapy, and so I could touch base with some of the PT related side, but I don't know, Christina, do you want to add a little bit on this?
Sure. So for, typically we'll do a sensory motor assessment to really determine what type of sensory stimulus that the patient responds to. We also like to personalize it, get some information from the responsible party, from the family, the friends, about preferences for taste, smells, different things like that, music. And then, depends on the patient's cognitive level. So based on their abilities and what abilities they still have. So it may be something like visual tracking. It may be that we're looking for certain facial expressions or turning the head. It may be, tactile sensory input versus, music therapy. So it's really individualized to the patient based on how they respond to the stimulus that's provided and trialed through the sensory assessment, the SMA. And then we create a unique sensory stimulation kit for that patient. And then at that point, sometimes activities is educated and they implement that into their one-on-one activities. But also if there's a caregiver or a family or friend that visits frequently, then we can certainly educate them as well to administer the sensory kit that we've established and do some of the sensory stimulation activities with that resident.
Great. What cognitive assessments does Aegis recommend be administered to develop baseline measures of cognition?
We use the Allen Cognitive Disability Model developed by Claudia Allen. And so we typically use, the Allen Cognitive Level Screen Tool. Also, sometimes people refer to it in, casual terms as the leather lacing, to get a baseline screen to then help guide us in identifying what are appropriate cognitive assessments for that patient. So we use the RTI sometimes, the routine task inventory. We might use components of the Allen Diagnostic Module, things like the placemat assessment, the key fob assessment, the bookmark assessment. And for some of our lower level patients, we use things like the SMA, the sensory motor assessment, or we may use the informal cognitive checklist tool. So it just is dependent on the patient's cognitive level that we get from the screen to guide us in determining the most appropriate additional assessments to administer to get an official Allen cognitive score.
Does insurance pay for therapy services in all levels of care?
Could you repeat that, Shyla?
Does insurance pay for therapy services in all levels of care?
Yes, insurance does pay for therapy services in all levels of care, unless the patient's on a skilled stay in the skilled unit. They'll be using their Part B benefits depending on, if they opted for Medicare Part B replacements, or do they have Medicare Part B in a secondary. It's mostly private pay, if not all private pay, so we have to validate what is their secondary, does it pay or not. But that's in every level of care, whether it's independent, assisted, memory care, or skilled nursing or long-term care.
All right, and that concludes the end of our questions. So thank you guys for coming, and we will see you next month. We hold these every month on the third Wednesday, so hope to see you guys again.